Our plan discuss the malaria. It's older disease from antique centuries. Population infected malaria. Scientists, antique doctors from antique Greece and antique Rome treated humans with malaria. But now its disease continue actual. And first drug, who is a first time used drug, a tropical drug against malaria parasites? In Indians and antique centuries used quinine, but European humans only 1638 first time understand quinine is effective drug and used, and only 1880 Laveran detected malaria parasites and confirmed it is a parasite infected human. Critical information. How many centuries population infected malaria? It is disease actual. And doctors, please look definition. What's mean malaria? And after we discuss actuality story, it is entrepreneur transmitted protozoal disease in humans, characterized by a cyclic cause, the possibility of relapse, manifested by febrile seizures, hepatosplenomegaly, and anemia. Doctors, please remember, it is entrepreneur transmissible disease. Source of infection only human, but mosquitoes only vector. What do mosquitoes? Bite ill person and vector transmit to healthy person and infected. And doctors, please copy. Actuality of a disease. Last century, 20th century, World Health Organization started program of liquidation malaria. And result this program in many countries, malaria liquidated. But it's done 100%, malaria parasites eliminated, and don't liquidated regions of malaria. And regions of malaria, tropic and subtropical countries. And 2 billion people in the world living in risk infected malaria. It's actual disease. And doctors every year registered 300 million ill persons of malaria. And prevalent, what is countries? It is South and Central America, Africa, all countries of Africa, but prevalent in the Sub-Saharan Africa, and Central and Southeast Asia, and islands of Oceania. It's actual disease, but the post-Soviet republics, two republic endemic of malaria. It is a malaria vivax. It is Tajikistan and Azerbaijan, where registered focus of malaria. And I said you, every year 300 million people infected malaria, and 90 million infected in the Sub-Saharan Africa, and every year registered 1 to 2 million lethal cases of a disease were prevalent children under 5 years ago. Why? Without immune response. Don't affected developing good immune response, and a high percent mortality of children registered in Africa continent because where registered high percent incidence of this disease. In the Europe, registered 2,000 cases of malaria, but it is cases connected with travel to endemic regions. Doctors, but you understand, this is not actual to endemic regions, and endemic regions actual too. But please look at this photo demonstrated who is group risk: children, our future. And who is group risk? Pregnant women, because on the pregnancy period, woman has immunosuppression, nature immunosuppression to keep newborn, and with time characterize severe cause of a disease. But what is kind of malaria and usually characterize severe cause at high percent mortality? Malaria falciparum, another name, tropical malaria, tropical. And how many species are you now? 5 species now registered. Malaria vivax, it is older species. Malaria vivax registered in the world. What is? It is usually Central and South America, Oceania, and Asia, and East countries of Africa, but infected Arabian humans. Negroid population is not infected. It is a result many centuries developed genetic resistance, and who Negroid race who live in the now North America don't infect malaria disease. Also, genetic material is a genetic resistance. It is result evolution to resistance against this infection agent. But how many centuries necessary was to develop it in resistance? And malaria vivax characterized usually moderate, don't develop in severe, because resistant rare. And next, malaria falciparum. I said you very actual disease, because high percent mortality connected with malaria falciparum. Registered in these regions, Central and South America, East Asia, and subtropical Sub-Saharan Africa. And next, malaria, registered prevalent in the islands of Oceania and Thailand. And malaria avale, registered malaria vivax, and rare cases registered in. But doctors, you visit all species of malaria, but you must maximum attended malaria falciparum, because all cases malaria falciparum characterize severe cause of disease. And please, etiology. What is etiologic agent? The pathogen belongs to the type Sporozoa, the family Plasmodium. In you and sorry, doctors, 5 5 species of malaria. It's younger. You don't now full information about this species. Plasmodium knowlesi, first time detected in the Malaysia, and characterized severe cause of a disease, and with severe cause as malaria falciparum. Infected not only human and infected monkeys. It is zooantropootic disease, but don't register it in the world. Why? And humans, 4 types of pathogen are parasitic. Plasmodium vivax causes 3-day malaria, Plasmodium malaria 4 days, Plasmodium falciparum tropical in our name, and Plasmodium avale 3-day malaria. And doctors, What's mean 3 day, 4 day? How many times lasting erythrocyte schizogonia will be discussed pathogenesis, and I say you how many times lasting erythrocyte schizogonia. In some regions of Southeast Asia, it is Malaysia, people are infected by zoonotic Plasmodium, Plasmodium novalis. And Plasmodium development cycles occur with a change host. And it is sexual development. It is named Sparagoni in the mosquito's body, in asexual development in the human. Human is host of the Plasmodium. And developing, it is schizogonia in the erythrocytes. In the human body, intermediate host, asexual development, schizogonia, and in the body of female mosquito of the genus Anopheles, final host, sexual development, Sparagoni. And doctors, why it is disease actual? Now you have insecticides against malaria parasites, but result administer insecticides toxical effect humans who live in these endemic regions, and parasites developing resistance against insecticides, and its disease continue active and affected world widespread. And doctors, resistance don't only against insecticides, and resistance against heterotropic drugs. I said you our century of resistance, antibiotics resistance, parasites resistance, antiviral resistance against all remedies. It's actual disease. It's actual problem for it. And doctors were registered. Don't all countries of Africa, all total countries of South America infected malaria. Regions where social conflicts where registered war occur, and where migration population, social and economical conflicts, where migration population through sanitary measures. Why? Because and prevalent in the village than city. Because necessary water is ponds, water, stay water, and high temperature. This is usually with good temperature to live mosquitoes, infected mosquitoes, and good temperature to Sporogonia, to malaria parasites in the mosquito's body. And this continue when infected parasitoids enter the human body, and within 15 to 45 minutes are introduced in the hepatocytes, and the exoerythrocytic development cycle, tissue schizogonia begins. Parasites form a tissue schizon in which they repeatedly divide to form small mononuclear forms merozoites. The minimum duration of tissue schizogonia. Doctors, what means tissue schizogonia? It is incubation period. Merozoites go to the bloodstream. Why developing clinical picture? Merozoites affected erythrocytes. But when the patient infected, first time schizons replicated in the liver. It is tissue schizogonia. And each parasite has specific time of replication, tissue schizogonia. Plasmodium vivax infection is 6 to 8 days, Plasmodium malaria 14 to 16 days, Plasmodium falciparum 5-7 days, and Plasmodium ovale 9 days. Doctors, how many times lasting incubation periods? This time lasting schizogonia. Have any questions? Schizogonia. And we'll be discussing epidemiology, doctors. What is mechanism? Transmissible. Mosquitoes must be bite a human, yes? And with parasites from bloodstream, first time go to the liver. In the liver, in the hepatocytes, replicated. It is the time, how many times replicated schizons, it is tissue schizogony. It's how many times lasting incubation period. When schizons leave hepatocytes and go to the bloodstream, developing clinical picture. Copy? I will now. Notice. Are you ready? Let's continue. And doctors, please look at a cycle of what I said to you. Mosquito bite human. And after this replicated in the liver and the liver cell and human liver stage, it is what is mean tissue schizogony and infected liver cell, and after leave liver cell and go to the blood and developing erythrocyte cycle. Exerythrocyte cycle, it is tissue schizogony. When replicated in the erythrocytes, developing erythrocyte schizogony. And first time developing trophozoite, it's younger from ring stage, and after grow and developing older stage, and developing after many times, developing gametocytes, sexual cells. When mosquito bite infected human, and these gametocytes keep in the saliva glands of the female mosquito. And this infected mosquito keep, and after can repeat infected bite healthy human and infected. But cycle when macrogametocytes and developing oocytes, and it is a sporogonic cycle in the body of mosquito. From microbiology course, you take this information, you study. You now discuss only exerythrocytic and erythrocytic cycle. And doctors, each parasite has specific time of erythrocyte cycle, exerythrocyte cycle, and erythrocyte. I said you, 3 days malaria. It is malaria vivax, malaria avalia, and 3 days lasting erythrocyte schizogony, malaria falciparum. And it is usually in the population name 3 days malaria, characterized malaria vivax and avalia. To doctors, to medicine, necessary say what is species of malaria vivax or avalia. And what is the peer? This result in the erythrocytes replicated merozoites and developing after 3 days, how many? It is 48 hour rupture erythrocyte and infected new erythrocytes. When schizons rupture erythrocytes go to the bloodstream, developing clinical signs. Do you understand? Cycle. Okay, continue. Epidemiology. Malaria natural focal infection. The main source and reservoir of infection is a human, sick or parasitic carrier. And vector, only what do you do vector? Transmitting. And mosquitoes of the genus Anopheles. And you understand, too, Anopheles must be good temperature and good condition. When temperature cool and less 16 degrees by centigrade, mosquitoes don't may keep these parasites in the body. And after winter, these mosquitoes leave these parasites and don't may infect healthy humans. Don't may play rule vector. Please copy. The transmission of the pathogen is carried out year-round in the tropical zone in areas with a subtropical and temperate climate. The transmission season is limited to the summer water period, which ensures the maturation of sporozoites in the body of mosquitoes. The key conditions for sporogony are favorable climatic conditions when the average daily temperature exceeds 16 degrees by centigrade for Plasmodium vivax, 16 for Plasmodium falciparum, 18, and the availability of breeding grounds for mosquitoes. And doctors, you understand why when temperature less 18, it is temperature don't connect, correlate with Plasmodium falciparum. Why Plasmodium falciparum prevalent, registered in tropical and subtropical regions?
Professor, can I ask a question?
Please, Dr. Isabel, please.
Yes, can I ask a question about the previous slide on the erythrocyte cycle? I understood that there are different times for each variant of the parasite to complete this cycle, but why is it important for us to differentiate how many days
discuss? Please wait, we'll be discussing, okay?
Okay, thank you.
It is, I repeat it for you. It's only first information, but will be discussed pathogenesis. I repeat, say for you.
Okay, thank you.
And now epidemiology, temperature, and you understand why it is disease actual in countries where high temperature. For example, this winter, this time, mosquitoes don't may fly, but doctors, don't only in endemic regions, but single cases which is in countries don't endemic regions. Why? Who live in the airport region? Because mosquitoes fly from aircraft and when temperature summer period, and by humans who live in a region of airport and infected. For example, when it was a hot temperature in Moscow, registered cases of malaria falciparum, humans who don't was in endemic regions. If you understand, it is airport malaria, another name, airport malaria. Please. And the duration of sporogony at an average daily temperature of 25 degrees centigrade is for Plasmodium falciparum 12 days, Plasmodium vivax 10 days, Plasmodium avale and Plasmodium malaria 16 days. At an average daily temperature below 15 degrees by centigrade, sporozoites don't develop. Copy? More than 280 species of mosquitoes of the genus Anopheles are known, of which only 70 are able to carry malaria plasmodium. There is a determination of various strains of plasmodium, even within one species, with certain types of mosquitoes, which determines the maintenance of a focus of infection. And doctors, all species present, many species present. And malaria cases are classified imported, secondary from imported, local, and vaccinated.
Professor, one more question.
Yes?
When you said that they don't develop under 15 Celsius, does it mean that the parasite is inactive, or if they...
Doctor, please, waiting. I say to you, it is only characteristic.
Okay, sorry.
Waiting. Copy and continue. Doctors, mechanism of transmission. Transmissible. It is basic mechanism. And transmission route through a mosquito bite. It is basic way of the disease. And transfusion for blood. Is in our name what is parenteral. But when will be patient infected from blood? When infected human and carrier donor, and you take blood and for example who carrier, and you infected recipient, and maybe infected human hospitalized in the clinic, and you may take instruments and infected, for example, needles, and in endemic regions, all blood must be examined not only to parenteral infection, and must be examined to malaria. For example, in our country, our donors don't examine it to malaria because it's not endemic regions. But maybe our patient, our donor, infected malaria 1 year ago, 2 years ago, and maybe developing carrier usually to malaria. Malaria, for example, lasting lifelong. Malaria falciparum 1-2 years, and a registered transfusion. For example, in our clinic, registered infected nurses after injection to patients with malaria falciparum, and transfusion for blood transfusion, organ transplantation, or other invasive medical procedures when schizons enter the systemic circulation, causing schizonic malaria. And doctors, vertical transmission from mother to fetus or newborn. It is usually registered where? In endemic regions where newborn infected. It is very critical, severe cases. Why? Because when infected newborns, these newborns don't have good immune response and developing high percent mortality. I said you high percent mortality children under 5 years ago.
So this is only falciparum?
Falciparum, yes, vertical transmission. No, vertical transmission, all species, but severe cause and lethal cases connected with falciparum.
We have just 2 ways for malaria.
For all malaria species.
The question you said some people was working. So he worked in the airport and he did take my passport of the work.
Who work in the airport, who live around airport, mosquitoes bite.
I know, maybe the party was higher infected in the disease. Maybe he's lived in North Europe. And North Europe is very
No, in Europe countries registered, for example, in the United States and Europe, in our city, Moscow, registered airport malaria. Single cases, but registered.
So we think that by
Mosquitoes come to your country, mosquito from aircraft come to an endemic country, and this time mosquito maybe bite humans walking around it and infected. But if mosquito live in many days, when temperature low 16, stop sporagony and don't make first days. It's rare, single cases. Usually, you must remember what is transmissible mechanism, yes? And rare cases, it is transfusion, and it's vertical actual, and airport malaria. Pathogenesis. The clinical manifestations of malaria are exclusively due to the development cycle of plasmodium in the erythrocytes or the circulatory bed erythrocytic schizogony. Doctors, all clinical picture connected with erythrocyte schizogony. In the erythrocytes, replicated merozoites, but to each species of malaria characterized type of erythrocyte schizogony. Malaria vivax, avale, and malaria falciparum have 48 hours schizogony, erythrocyte schizogony. And you understand, after 48 hours, what do? The cells leave erythrocytes and infected new erythrocytes. But product metabolism of merozoites this time go to the bloodstream and 48 hours replicated, and when go to the rupture of a wall of erythrocytes, and metabolic products of merozoites go to the bloodstream, and detox part of erythrocytes go to the bloodstream. What do human body? Increase temperature against these metabolic products and developing clinical picture. And the stage of tissue, in our name, exerythrocyte schizogony, in the liver, schizogony has no clinical manifestation and corresponds to the incubation period, I said you. But each species has specific type of tissue schizogony. For example, maximum days characterized malaria lasting 14 to 16 days. Why necessary now for you? For example, our patient returned from endemic regions 6 months ago. Are you connected with disease with travel to endemic region? No. And that present specific characteristic. And for example, patient returned from Africa 1 week ago and was 1 month. It's connected, yes? It's connected with travel to endemic region. And why necessary now for you to connect with epidemiological data? The development cycles of plasmodia in the human body are characterized by indirect translation from tissue to erythrocyte schizogony. Result, tissue schizogony absent clinical signs. And after merozoids leave hepatocytes and affected erythrocytes and replicated in the erythrocytes. And doctors usually specific characteristic when products merozoids go to the bloodstream. First time, patients feel chilling. After increased temperature, and third step, it is appears sweet. It is named paroxysm. Specific. For example, will be discussed influenza. Characterized patients feel chilling, increased temperature, but won't develop sweet. It is specific characteristic. Three signs: chill, fever, and sweet. It is named paroxysm. Malaria paroxysm. And after temperature normalization. Why? Because all metabolic products disappear, but what do? Merozoids affected new erythrocytes and continue erythrocyte schizophrenia. I repeat it. Erythrocyte schizophrenia characterized lasting 48 hours for malaria vivax, avale, and falciparum. Malaria has 72 hours. 72. How many days? 3 days. Malaria vivax, avale, and falciparum have 38 hours. 48. 40 plus 8. 48. Lasting erythrocyte schizophrenia 48 hours. And malaria has 72 hours. 72 hours. First time chill, next fever, still lasting maybe 15 minutes to 1 hour, 1/2 hour. After increased temperature high will be 3 hours, 6 hours, and after temperature drop, and patients feel sweaty. And after temperature normalization, doctors will be discussed clinical picture. Any questions? And please continue. Feverish paroxysm due to the completion of the cycle of erythrocyte schizophrenia, the destruction of red blood cells, whatsoever in erythrocytes, destruction of erythrocytes with access to the circulatory bed, a large number of merozoids, metabolic products, toxic substances, and fragments of cell walls. The clinical manifestation of febrile paroxysms occurs when the level of parasites in the blood reaches the pyrogenic threshold. Doctors, boys from another group, please write your name and please write me in another group. Please from another group. And doctors, you understand clinical picture connected when products of merozoids go to the bloodstream. When merozoid products disappear, developing apyrexia period condition, patients normal. But after 48 hours, repeat metabolic products go to the bloodstream and repeat appear paroxysm. And you understand, malaria don't characterize everyday high temperature. but it is characterized to malaria vivax, avalia, and malaria. But to malaria falciparum don't characterize a pyrexia period. Why? Because level of parasitemia very high, and patient has 2 or maybe 3 generations. This day live 1 generation of merozoites. Next day live erythrocyte, 2nd generation of merozoites. And why malaria falciparum characterized severe cause? Younger parasite than another parasite. And in the absent time to evolution of human body, resistance against this parasite. And to malaria falciparum, you understand, characterized times of erythrocyte 48 hours, but every day or maybe 2 times each day, patient has paroxysm. Do you understand? Okay, continue. Are you copied? The merozoites released during the destruction of erythrocytes are reintroduced into new intact erythrocytes, in which their development cycle is repeated with the subsequent destruction of erythrocytes. Plasmodium vivax and Plasmodium avaria predominantly infected young erythrocytes. Plasmodium malaria, nature erythrocyte, but Plasmodium falciparum affected all stages development erythrocytes, younger and older. Affected erythrocytes with varying degrees of maturity. And you understand, place of affected very high than place of affected, for example, Plasmodium vivax. And level parasitemia very high to Plasmodium falciparum. Yes, varying degree. Affected older and younger erythrocytes. I said you, malaria vivax and avalia like only younger erythrocytes. Plasmodium malaria major erythrocytes. But to malaria falciparum, don't necessarily younger, all total erythrocytes, all the stage of degree affected. And increased place of affection place. And you understand why level parasitemia higher. Copied? Continue. Each cycle of erythrocytic schizogony repeats itself with absolute precision. In vivax, Plasmodium avalia, and Plasmodium falciparum, malaria, it is every, how many? I said 48 hours. And doctors, after today, first day, second day, on the third day, why name of malaria, vivax and avalia, 3 days malaria. This day, patient has paroxysm. Second day, paroxysm absent, temperature normal. And third day, repeat appear paroxysm. And to malaria falciparum, you wait these types of temperature curve. But I said many generations of malaria falciparum, and every day patient has paroxysms. But Plasmodium malaria every 72 hours. And which day paroxysm, and second day normal temperature, third day normal temperature, on the fourth day increased temperature. And since humus infection occurs with different generations of Plasmodium, asynchrony is noted in the cycles of erythrocytic schizogony. Copy? Continue. And with the formation of immunity, the ability to parasitize in erythrocyte receives only one, the most numerous generation of parasites, which determines the synchronism of the resulting paroxysm. Only in Plasmodium falciparum malaria can several generations, I said you 3, 4 generations of Plasmodium circulate simultaneously. And you understand, absent time to arrest to human, every day high temperature and 2 paroxysms every day, and condition worse. And doctors, by developing clinical picture, result, merozoites leave erythrocytes and metabolic products go to the bloodstream. Why developing paroxysm? And together, if erythrocytes affected, what is appear? Anemia, anemia. When developing marked anemia, what is color of the skin? Yellowness and lemon. We discussed viral hepatitis. I said when developing cholestasis complication, bile stain, color of skin usually as orange. But in our slow jaundice, it is as lemon, characterized when developing hemolytic anemia, hemolysis of erythrocyte, hemolytic jaundice. Continue. Copied? Under the influence of parasitemia, the complement system is activated. The production of cytokines occurs, which leads to damage to the endothelium of the macrovasculature. Doctors, severe cause disturbs function of important organs characterized to malaria falciparum. Level parasitemia very high. And what do? Affected erythrocytes are connected with normal erythrocyte. And with developing, what is developing? Microthrombosis of vessels. Developing microthrombosis disturbs vascularization, absent oxygenation, and disturbs function of the important organs. First time it is brain, and developing a cerebral fog, brain edema. Erythrocytes infected with Plasmodium falciparum acquire an increased ability of adhesion to the endothelium of the macrovasculature and developing cytoadhesion. And doctors, what is specific characteristic? Malaria, vivax, and avalia, I said you characterized moderate course of disease. Why? Because circulated in the circuitous vessels. You know, diameter of circuitous vessels large than microcirculatory vessels. But Plasmodium falciparum like tissue, like microcirculatory vessels. And diameter is small than secretory vessels. And sludge syndrome, what means sludge? When affected erythrocytes connected with normal erythrocytes. It is erythrocytes connected with endothelium of the vessel and developing microthrombosis. Doctors, I write notes because your teacher must be examined your notes. Do you understand? And doctors, if affected important organs, you understand clinical picture malaria falciparum will be another than malaria vivax and avale. Characterized polymorphism clinical picture because affected vascularization of the brain, vascularization of the kidney, intestine, lungs, generalized process of the disease. For example, malaria vivax and avale, you understand, increased temperature, characterized paroxysms, and appear severe causes, the hemolytic jaundice. But falciparum don't characterize with absent paroxysms when developing apyrexia. And difficult diagnostic malaria falciparum only when you want basic true clinical picture. Necessary only laboratory examination. Copied? And theta adhesions leads to the accumulation, in our name, sequestration of affected erythrocytes in the macrovascular vessels of internal organs, and first of all of the brain, kidneys, bone marrow, liver, intestines, and other organs. Disturbs function with important organs and systems. Violation of microcirculation of internal organs leads to hypoxia, while disturbs vascularization, absent oxygenation, developing hypoxia. And if hypoxia increase, what is acidosis, metabolic acidosis and tissue acidosis, impaired trapezium, functional failure, and ultimately, what will be? Lethal outcome. Copied? And doctors, please look, electron microscopy. Please look, it is affected erythrocyte where replicated malaria parasite where keep merozoites. And this erythrocyte connected with healthy normal erythrocyte and developing what is sludge syndrome and asthmanism connected and disturbed microthrombose of vessel. Illustrating adhesion protein clumps. And important links in the pathogenesis of malaria are the development of disseminated intravascular coagulation, anemia, inhibition of gematopoiesis, impaired liver function, damage to the organs of the reticular endothelial system. The pyrogenic threshold at which febrile paroxysm manifests itself is individual, depends on the reactivity of the organism prior to immunization. In non-immune individuals, it is a few tens of parasites in 1 microliter of blood. Partially immune people have thousands of parasites in 1 microliter of blood. Doctors, what is the peer? Result, this stops vascularization of organs, stops vascularization of microtubule vessels of the brain. This stops liquid dynamics and appear brain of the edema of the brain and developing clinical picture encephalopathy. I said you, pathomorphologic basic of encephalopathy, it is brain edema. Together, what is it here? Disturbs vascularization of the wall of intestine. What is it here? Secretory diarrhea, because activated adrenal system and developing diarrhea. And disturbs vascularization of the kidney. What is it here? Acute renal insufficiency. And disturbs vascularization of the lungs. What is it here? Edema of the lungs. Clinical manifestations. And it is with clinical picture characterized by falciparum. Together, synthesis level parasitemia higher against parasites developing what is antibodies and developing complex, web representative complex in the liver and developing mesenchymal inflammation and increased size of the liver. But before increased liver, first time increased spleen. Why? Affected erythrocytes. What do you do affect erythrocytes? Well, go to the spleen, yes? And you know, what's function of the spleen to adults? Only keep affected erythrocytes. And first time increase spleen size. And after increase liver size. And doctors, from pathogenesis, you understand clinical picture. What is first manifestation? High temperature. Yes, malaria vivox and the valley characterized paroxysm. Chill, fever, weak. Next day, temperature normal. Third day, repeat increase. And increase spleen size because of developing cytolysis of erythrocytes. And after increase liver and hemolytic jaundice. To malaria falciparum characterized severe cause to unimmune humans who had contact with malaria in the childhood period, usually, and don't live endemic region, every time has non-sterilized immunity and characterized moderate course of the disease, as influenza every season. But who unimmunized humans, it is who from unendemic regions and pregnant women in endemic regions and children characterize severe course when increased temperature, but absent period apyrexia because level parasitemia high and several generations persistent, and together developing severe cause disturbs of function of the brain, developing clinical picture encephalopathy, developing what is diarrhea, or maybe developing edema of the lungs and renal insufficiency. Immunity in malaria is non-sterilized species and non-specific, unstable, and short-lived. What means? Who infected malaria vivax may be infected malaria falciparum, absent cross-immune response. And who live in endemic country every year infected malaria, take malaria parasites, and developing non-sterilized immune response. But who live in endemic country, for example, students who to, for example, and studying during 5-6 years, and after return, infected as first time when developing high temperature and developing a severe course of a disease with developing complications. But I said you to persons who live in endemic regions characterize developing evolution resistance. We will be discussed after address. Have you questions about pathogenesis? Do you understand? Doctors, please remember, when disturbs vascularization, disturbs function of all organs. Together, when a patient has malaria falciparum, drop sugar. Why sugar drop? Glucose drop. Developing hypoglycemia. Why? Parasites add glucose. It's food for glucose. Together, disturbs glucogenesis and increase insulin level high and decrease glucose. If decrease glucose, what patient condition? Drop of consciousness. Okay. How many times are you on to coffee break? 15. Okay. Doctors online, please, after 15 minutes, return to this link platform. Okay? Zoom link. Okay. Doctors, arrest. Characterized engine, not only immunity against after disease, patient has immune response against infection agent. I said humans from Western Africa don't infected malaria falciparum. Why? Because it is connected with the absent is the antigen DAFI. Is the antigen DAFI? It is antigen to presentated malaria parasites. It is result evolution. Don't infected malaria who have is antigen DAFI. Don't infected malaria, sorry, vivax. No, vivax. Malaria falciparum, it is relative immunity, and it is who have problems with hemoglobin, abnormal hemoglobin S. Don't infect it, or if infected, characterized moderate course of the disease. It's not characterized to Western Africa, it's all continent. But who live in Western Africa don't infect Plasmodium vivax. And another humans who have a defect of hemoglobin S, it is anemia, it is disease. But with humans is don't infected malaria falciparum, or if infected, characterized moderate course of a disease. And who have deficit of glucose 6-phosphate dehydrogenase, characterized mild or moderate course of a disease, because it is antigen to presentation malaria falciparum. And result who live in the whole and hyper-endemic regions, because every year infected, have non-sterilized immune response, post-infection immunity, and newborns from these regions usually is not infected. Why? Because during pregnancy, these newborns take from mother antibodies, and first years of life, first year of the life is not infected. Why? In when may be infected? When change character of feeding. Because when newborn feeding breast milk, take antibodies from mother. Change character feeding when in the breast milk absent paraminobenzoic acid. But when in our products, take paraminobenzoic acid. Paraminobenzoic acid, it is antigen to presentation of malaria parasites. And with situation. But what's mean polar and hyperendemic regions? Regions where a high percent humans with increased spleen. Usually presents two indexes of endemicity: parasitic index, spleen index, and endemic index. And parasitic index, what's mean? How many percent persons from population have parasites? 1, 2, but present parasites. It is parasitic index. But characterized morbidity rate in countries, it is spleen index. What means spleen index? When you examine, for example, 1,000 humans from this country, from this region, and 10% have increased size of spleen. It is hyperendemic region, hyperendemic, low. And from 11% to 50%, it is mesoendemic. Risk infected, mesoendemic. And hyperendemic, when more 50% persons have high increased spleen size. It is hyperendemic. And holoendemic, 75% of examined humans have increased spleen size. It is holoendemic. And where risk infected higher? Holo and hyperendemic regions. It is information about immunity. And next step, it is classification and clinical picture. Please look, depending on the type of plasmodium, there, pre-day, malaria, vivax, pre-day, malaria, avalia, 4-day, malaria, and tropical malaria, it is malaria falciparum. But you don't say malaria 3 days or 4 days, because every day patient has paroxysm. But for malaria falciparum characterized 48 hours erythrocytosis as erythrocytosis of malaria vivax and avalia. On the recommendation of World Health Organization, they are uncomplicated, severe, and complicated malaria. Usually uncomplicated malaria and severe malaria characterized to malaria vivax, avalia, and malaria, but severe and complicated characterized to malaria falciparum. Doctors, before developing one generation, first days of a disease, patient every day had high temperature, every day. But after first 3 days, developed one generation of parasites, and after developing period when patient has paroxysm, next day apyroxia period. We discuss malaria vivax, avalia, and malaria. Please look temperature curve. Malaria vivax, patient condition increase. Next day, first day. Second day, normalization. Third day, repeat increase. Next day, normalization. But malaria, in our name, 4 days malaria. First day, temperature high, patient has paroxysm. Second day, temperature normal. Third day, temperature normal. On the fourth day, repeat increased temperature. Why? Doctors, please, you know from pathogenesis. First day, what means? When malaria virusoids replicated in the erythrocytes and leave erythrocyte. This time, what is appear? Paroxysm. Yes, chill, a fever, and with wind. But this time, what do you do? Virusoids infected new erythrocytes, and this time patient had high temperature. And this time, why? Because in the bloodstream, metabolic products present, but this time virusoids affected new erythrocytes. It is first day, yes? And first day, patient has high temperature. And second day, it is 24 hours. Next day, 48 hours, temperature normal, because metabolic products disappear and virusoids continue replicating in the erythrocytes. After 48 hours, what do you do, virusoids? Leave erythrocytes. And third day, increase temperature. And doctors, 48 hours lasted erythrocyte schizophrenia, but only one day patient has normal temperature, apyrexia. First day, paroxysm, it is first 24 hours. Second day, it is plus 24 hours, will be 48 hours. On the third day, repeat increased temperature. Do you understand me? It is characteristic of malaria, vivax and avale temperature curve. And specific characteristic, malaria, vivax and avale, when developing tissue schizophrenia, only one generation of virusoids leave of liver. It is tachyform, but present bradiform.
One generation of virusoids live
from liver. Please look. In the liver, replicated schizons, yes? And schizon usually live of liver. Well, it is one generation, characterized to viva malaria falciparum and malaria. And after, in the liver, absent virusoids, because total it is replicated and live. But vivax and avale specific characteristic, present two generations in the liver tissue. It is bradiform and tachyform. First, when developing clinical picture, tachyform, leave liver and affected erythrocytes, and developing clinical picture. But bradiform don't leave liver and sitting and waiting, and activated only after 6 to 8 months, or maybe after 10 to 12 months, and developing later relapse. Vivax and avale have two tissue generation, bradiforms and tachyforms. Tachyforms leave liver and affected erythrocyte, but bradiforms continue stay in the hepatocyte and waited and activated after 6 or 8 months, or maybe 10 to 12 months. And two, vivax and avale characterize later relapse. And continue. Malaria. How many times lasted erythrocyte schizophrenia? 72. What is it here? Please look. First day, when virusoids leave erythrocytes, developing what is paroxysm, and patient condition severe. Yes, and but next day these products of metabolic products disappear and temperature normal. It is what is 48 hours. And next third day, temperature normal. How many times? 72 hours. And after 72 hours, repeat increased temperature. Because after 72 hours, merozoites leave erythrocytes and repeat increased temperature. And temperature curve of malaria. Malaria, first day, high temperature, and 2 days, normal temperature, second and third day, and fourth day, repeat increased temperature. And another name, fourth day malaria. On the fourth day, increased temperature. You understand me? And U18, to malaria falciparum must be on the second day, normal temperature. Because this erythrocytosis lasted 48 hours as Plasmodium vivax and avali. But please look, temperature curve. This day, first day, temperature 40, moderate decrease to 39, but repeat increase to 41. In the morning and evening, you detected 2 paroxysms. Next day, temperature dropped to 37, 36, but repeat increase, not normalization. Short time decrease, but repeat increase, and patient has high temperature in the morning, in the evening, and moderate decrease to 37, and repeat increase. It is in irregular temperature curve when patient condition worse, absent time to arrest. Every day temperature increase, and 2 times every day. Please look, doctor, in the morning, in the evening. Moderate decrease to 39, repeat increase. Not normalization, decrease to 37 and repeat increase. But why? Your question. 48 lasting erythrocytosis. Why absent 1 day arrest, apyrexia period? Why? Because how many durations persisted? 2 or more. Because level parasitemia very high. And this temperature peak paroxysm connected with first generation, second paroxysm connected with when appears second generation, and third paroxysm connected with go to the bloodstream, third generation. And every day patient has high temperature. And severity correlate with level parasitemia. When parasites more, what is developing? Disturbance of microcirculation of the vessels. Do you understand? Continue. Relapses, depending on the timing of occurrence, there early up to 2 months, but later over 2 months. Doctors who have later relapse, Plasmodium and avali, distinguished by origin erythrocyte and exerythrocyte recurrence. Erythrocyte recurrence characterized to all species of malaria, but exerythrocyte to malaria vivax and avali, where activated Brady forms. COVID? Continue. Erythrocyte relapses can develop with any form of malaria. Since they are caused by not complete sanitation of the body from plasmodia. Erythrocyte, another name, what is tissue relapses, develop only when Plasmodium vivax and Plasmodium avale are infected, which is due to late activation with bradiform, another name, gymnozoids, in the patient's liver. Because malaria vivax and avale have two tissue generation, bradiform and tachyform. In the course of a disease, primary malaria and relapses are isolated. Do you understand, doctors? Okay. And you understand temperature curve?
Yeah.
Why? How many days lasting apyruxia period? 1 day or 2 days? 2 days is characterized to malaria. Malaria vivax and avale, 1 day apyruxia period. 1 day paroxysm, 2nd day apyruxia. 1 day paroxysm, 2nd day apyruxia. Sorry. And we must now discuss malaria. Before malaria falciparum, I want to discuss with you 3 days malaria by vivax and avale. What is characteristic? Paroxysm, it's intoxication syndrome, and increase spleen and liver. What is complication are you waiting? If patient has intoxication syndrome, what is complication may be developing? Common principle, doctors. You must remember for all infection diseases. If present high temperature, intoxication syndrome, what complication may be developing? No. Jaundice, its result affected liver cells or erythrocytes. Intoxication syndrome, severe intoxication syndrome, infection toxical shock. And when developing severe cause, developing infection toxical shock. And developing hemolysis of erythrocytes and maybe developing what is hemolytic anemia. When examinated, you detected increased spleen and increased liver size. And first days, patient has high temperature every day, first day, second day, but after 3 days, appear periods, paroxysm and apyruxia, necessary time to develop in 1 generation of parasites. And it is clinical picture of malaria vivax and malaria. Only how many days lasting? Malaria. 4 days malaria. First day paroxysm, 2 days normal temperature, 4th day repeat increased temperature. But clinical picture: paroxysms, apyruxia period, intoxication, increased spleen and liver, and appear hemolytic anemia. But I said you, malaria falciparum characterized polymorphic clinical picture. Incubation period lasts 8 to 16 days. Clinically more severe than other forms of malaria. More often begins acutely, suddenly, without prodromal phenomena, with an increase in body temperature to 38 to 39 or maybe 40. The cyclical nature of febrile paroxysms is not typical due to the asynchrony of the cycles of erythrocytic schizogony. The onset of the disease is manifested by chills and the development of an initial fever lasting several days, from 3 to 8. Periods of apyrexia are not typical. The temperature curve is often of the round type, irregular, less often the remitting type. Copy it? Continue. Okay. Are you ready? Okay, continue. A severe course is characterized by high temperature, up to 40 degrees by centigrade and above, and prolonged 8 or more days fever. But doctors, if every day patient has temperature 40, will be one out, what is outcome? Only one that, because temperature high, temperature 40 is don't connect with human life, yes? And what is the usual developing? Total microthrombosis. Enlargement of the liver and spleen is noted within a few days from the onset of the attack. Typically a violation of pigment metabolism and an increase in the level of aminotransferases. Disturbances in the hemostatic system can be detected. Cardiovascular disorders include tachycardia, decreased BP, hypertension, muffled heart sounds. Are you tight? Are you tight? Oh, you sleep on the desk. Drop on the desk. Copy?
Yes.
Continue. Disturbances from the central nervous system are characteristic of headache, dizziness, vomiting, meningeal signs, drowsiness, convulsions. Unlike the complicated cerebral form, consciousness is well preserved. Typical hemolytic anemia, leukopenia, neutropenia, relative lymphomonocytosis, thrombocytopenia, accelerated ESR. Doctors, you understand why developing disturbance of central nervous system? It results in edema. I said pathomorphologic basic of cerebral form encephalopathy, it is edema of the brain. Result disturbs vascularization, disturbs liquid dynamics and developing edema. But my question for you, why developing anemia? You understand, it results cytolysis of erythrocytes. But why appear leukopenia and thrombocytopenia? No, leukocytes, white blood cells. Yes, toxical effect, bone marrow effect. And together, what do erythrocytes? With affected erythrocytes connected of all elements of the blood. And connected with erythrocytes, connected leukocytes, and change of electrocardiography, a decrease in the ST segment and decrease in the R voltage and negative T wave. In the absence of antiparasitic treatment in non-immune individuals, the disease has an unfavorable outcome or phenomenon. In that case, tropical malaria. It's another name. What is? Falciparum. Vivox and Davali 3 days. It's usual population say tropical, and medicine doctors and who work in medicine, falciparum. Falco? Maybe. In our country, rare registered malaria valley, usually Vivox and falciparum, because who return from endemic regions, who work in endemic regions, usually affected falciparum. Copy and continue. Most often errors in the diagnosis of malaria falciparum are associated with the absence in patients of typical febrile paroxysm. Usually, you waiting. If patient has malaria, you waiting paroxysm. What means paroxysm? Chill, fever, and sweat. It is paroxysm. As well as frequently detected disorders of the respiratory and gastrointestinal tract. What is disorder of gastrointestinal tract? Diarrhea and multiple vomiting. And doctors, in our clinic, registered false mistakes of doctors and false diagnosis, patient hospitalized. and from ambulance hospitalized intestinal infection. Acute intestinal infection. Why? Because patient has high temperature, multiple vomiting, and 2-3 times diarrhea. But when you examine patient, you understand high temperature will be discussed Friday, food poisoning and salmonellosis. High temperature is don't characterize to intestinal infection diseases. 40 don't characterize to localized forms. Only to generalized form will be discussed Wednesday, typhoid fever. But patient condition marked severe, it's not characterized to intestinal infections. And first time, what's help to you? You must, when talking with patient, you must take anamnesis, epidemiological anamnesis, where patient was before developing clinical picture during 1 month. And if patient return from endemic regions, first time you must examine it to malaria. Doctors in all plan examination of fever patients, you know, work and diagnose fever unknown etiology before examining patients take full analysis. You must be examined to malaria. Maybe this patient don't have a clinical epidemiological data from connected to malaria, for example, return from endemic regions. But patient has prolonged fever. This fever don't answer to antipyretic drugs. You must be examined to malaria. Why? I said you registered acute malaria too. Rare but registered. And respiratory disorders. What is clinical picture? Cough, and developing what is disturbs of breathing. Yes, and necessary administer X-ray examination and to malaria examination. Specific analysis will be discussed later. Do you understand? Clinical picture of malaria falciparum. Doctors, please don't wait in paroxysm and apyrexia period. It's don't characterize to malaria falciparum. In regular temperature, severe course of a disease, and polymorphic clinical picture. Continue. 3 days malaria, the incubation period lasts is 10 to 21 days, or 6 or 14 weeks, less often longer. Clinically, Plasmodium vivax malaria is milder and more favorable than malaria falciparum, although not only severe but also fatal causes are possible. Often the fever at the onset of a disease, if of an irregular nature, which is explained by the asynchronous release of several generations of parasites into the bloodstream. But it is only lasting short time. After developed one generation, with formation of immunity and circulation in the blood of the only generation of Plasmodia, paroxysms acquire a typical appearance with the clear identification of the phases of chill, fever, and sweat. Topic? Please. And relapse, late relapse, it results activated radiforms, and after 6 months. Why necessary now for doctors? Incubation period. Patient returned from endemic regions, for example, 1-2 weeks ago. Connect disease. But patient said to you, I don't infected. I don't was in endemic region during 1 month. But if patient infected 6 months ago and had high temperature, maybe don't examine it, because immune response very good and so native parasites, and after 1 week, 2 weeks, clinical picture disappear. But after 6 months, repeat clinical picture. And maybe patient necessary maximum attention to when you're talking with your patient. If patient had 6 months ago or 1 year ago high temperature, and maybe patient had malaria vivax 6 months ago, you understand what is the situation. It is later relapse, result activated radiforms. Or maybe patient returned from the many days lasting late relapse, because you administer therapy. Will be discussed what therapy has to administer. Will be discussed later therapy. After discuss clinical. Copy this slide. Please copy. Copy. Continue. Typical attacks occur every other day and usually at the same time. The chill lasts from 20 minutes to 4 hours. I said it 30 minutes, 15 minutes, maximum 2 hours. Fever from 2 to 8 hours. Further decrease in temperature within 1 to 2 hours with profuse sweating. And the period of apyrexia lasts about 40 hours, but it is end of first day and plus second day. After several attacks, an increase in the liver and spleen is determined. First time increase spleen, and after increase liver. Laboratory signs of hyperchromic anemia are detected gradually, starting from the second week of the disease. Copied? Copied? In the absence of anti-parasitic treatment, After 12 to 14 paroxysms, the intensity decreases and they gradually fade away, while the frequency of the occurrence remains unchanged. A few weeks later, from 2 to 8, seizures reappear due to the development of early erythrocyte relapses may appear. If the patient didn't undergo histoschizotropic therapy against bloody forms, why histo? Because in the tissue and tissue schizogonia, after a few months, from 6 to 8, to a maximum of 3 years, due to activation of bradiforms, hypnozoids, and developing late relapse. What is relapse? Exoerythrocyte. Result activated bradiforms, hypnoforms. And clinical picture as first time, what is paroxysm, apyrexia, paroxysm, apyrexia. Copied? No. Okay, copy. Histoschizotropic tissue, hista, another name, Latin term, histology. What is histology? It is a science study tissue. Tissue schizogonia, another histology, histoschizotropic. Yes, again, bradiforms. And usually will be discussed, recommended, you first time administer therapy against erythrocyte schizogonia, and second course, before developing relapse, administer against tissue schizogonia. Copied? Girls, are you ready? Who will say, oh, doctors. Next, the incubation period, malaria avale, lasts 11 to 16 days. And in many clinical and pathogenetic parameters, avale malaria is similar to malaria caused by Plasmodium. Before laboratory examination, you don't understand what is malaria, vivax or avale, because times when developing paroxysm, how many? 1 day, yes, after 1 day, on the 3 days malaria, first day paroxysm, second day normal temperature, third day repeat increased temperature. Typically mild course of a disease with few seizures, which is explained by the low level of parasitemia and the rapid formation of immunity. And in the world, malaria avale registered rare than malaria vivax and malaria falciparum. Plasmodium avale has a great tendency to primary latency of the disease, which is manifested by prolongation of the incubation period to several months or even 2 or more years. Copy? Yes, to avale characterize bradiform, and to malaria avale and malaria vivax characterize bradiform. And clinical picture, I said, you common.
So is there any differences between the two brands?
Before laboratory test, you don't understand what is malaria. Usually, to malaria avale characterize prevalent mild cause. To malaria vivax moderate prevalent, rare severe cause. And on the mail we have to you epidemiological data, where geographic regions where patient was, but and common maybe. And 4 days malaria, another name, malaria. The incubation period is 25 to 30 days. Prolongation up to 6 weeks is possible. Usually the disease begins signs and initial fever. Febrile seizures last about 30 hours at interval of 2 days. You know why it is connected, how many days, times lasting, erythrocyte schizophrenia. Erythrocyte schizophrenia lasting how many times? 72 hours, yes. And after 72 hours, repeat paroxysm. First day when developing paroxysm together with time affected new erythrocytes. It's time when it is parasites leave erythrocytes developing paroxysm together with time developing erythrocyte schizophrenia. Anemia, enlargement of the liver and spleen, develop slowly, not earlier than the 3rd week of the disease. A favorable course of the disease is characteristic, however, in endemic regions. Children may develop nephrotic syndrome with a poor prognosis. And doctors, when developing nephrotic syndrome, when patients use atypical drugs, may be developing clinical picture, renal insufficiency, renal nephrotic syndrome. Copy. Continue. Girls, are you ready? Nephrotic syndrome is characterized by increasing proteinuria, hypoproteinemia, edema, increased blood pressure, signs of renal failure. You know, when affected kidney, usually it is complication connected with patient's life and maybe developing outcome death. Poor prognosis due to malarial nephropathy, not responded to treatment with either anti-malarial drugs or glucocorticosteroids. If plasmodium remain in the blood after a disease, a long-term parasite carrier is formed without activation of erythrocyte schizophrenia. Copied? Nephrotic syndrome characterized to clinical picture of malaria, but who use anti-malaria drugs, malaria, for example, falciparum, developing nephrotic syndrome result to the total parasites affected, and with antigens higher and affected kidney. We will be discuss examination, laboratory examination. But after malaria, who infected malaria? Malaria usually parasites persisted lifelong. Load of parasitemia, but will be source of infection. Don't parasites leave human body? Malaria characterized. Maybe appear relapses, but without relapses, but persistent low load. Copied? Okay, continue. And features indicates poor prognosis in severe malaria falciparum. You know, from all species of malaria falciparum characterized developing severe cause will developing life-connected complications. And is marked agitation, hyperventilation, respiratory distress syndrome, hypothermia, decreased temperature, bleeding, deep coma, repeated convulsions, anuria, and shock. This clinical data. Result, disturbed coagulation, developing bleeding. Why developing deep coma? Edema of the brain. Why developing shock? Infection, toxic shock, and shock of when developing edema of the brain. And why developing anuria? Affected kidney. Алло. Чуть попозже позвоню, мы сейчас переживем. Copy. Continue. Laboratory. I said you drop glucose, hyperglycemia. Why? You know, what do parasites? Like glucose. Yes, and together disturbs vascularization of the pancreas and activated glucogenesis. Yes, and developing hypoglycemia, and together developing hyperlactatemia. And why developing acidosis? Microthrombosis of vessels, developing hypoxia of the tissue. Why increased serum creatinine? Result, a disorder of the kidney failure, yes, renal failure, and elevated total bilirubin. Result, what is developing? No liver. Bilirubin. Result, hemolysis of erythrocytes. And liver enzymes increase, yes. It result developing parenchymatous diffusion. Why? Because, doctors, but it is level enzymes is not very higher than acute viral hepatitis. It is hundreds, no thousands. Why? Because immune complex sitting in the liver, and elevated muscle enzymes, creatine phosphokinase, myoglobin, disturbs vascularization. It is result tissue acidosis, increased creatine phosphokinase, and elevated urine. Why? It is affected kidney. And the chemical, this analysis only characterize disturbs function. It characterize severity of disease, but don't confirm diagnosis. Doctors, please remember, diagnosis confirm only a specific analysis where you detected infection agent and when you detected anti-immune response against infection agent. but the chemical data, hemogram data characterize severity of disease, yes, and function of the or important organs and systems. And doctors, please remember, all clinical pictures connected with pathogenesis, mechanisms of disease. Copy? Okay, waiting. Boyd? Already? Okay, continue. And hematology. Leukocytosis, severe cause leukocytosis, severe anemia, coagulopathy, decreased platelet count, and prolonged prothrombin time, prolonged partial thromboplastin time, and decreased fibrinogen. What is characterized disturbs coagulation system. Why you increase leukocytes? Drop erythrocytes and increase leukocytes. Why developing leukocytosis? Why? Because elements of the blood erythrocytes drop, and leukocytes connection with erythrocytes increase leukocytes. Bad prognostic sign when increase leukocytes. Leukopenia was result with erythrocyte connected, but leukocytosis absent erythrocytes. Copied? Continue. Doctor, are you ready?
Yes.
And doctors, but confirm diagnosis when you detect parasite. And parasitology analysis, hyperparasitemia, high-level parasites. When high level of parasitemia exceeding 100,000 in 1 microliter of blood. Usually when detected 50,000 parasites, it's very high, but 100,000 parasites, it is bad prognostic sign. Increased mortality at 100 and high mortality at 500. And more 20% of parasites identified as pigment containing trophozoites and schizoids, all stages of plasmodium falciparum development in peripheral blood. Doctors usually characterize to malaria falciparum only younger form, what is rim forms. Schizoids in the rim form detected. But when you detected all stages of parasites, you understand What is developing? Rupture of all vessels. And you detected, it is bad prognostic sign when you detected all stages of plasmodia. And when more 5% of neutrophils with visible pigments. Copy? Okay, copy. All stages. Usually, when you detect it only as younger form, it is RIM. She's on in the RIM form. It is prognostic good, satisfactory. No good, satisfactory. But when you detected all stages, all the and younger plasmodium is bad because developing total rupture of erythrocytes and disturbance of markers of vessels. Bad prognostic. Copied? Boys, are you copied? Please give me your notes. You don't walking, only you talking with your friend. Yes. Okay. And complications. The high risk of developing severe and complicated forms of malaria who is younger children under 5 years, pregnant women, and primary patients who come to endemic regions from unendemic regions. And aborigines from endemic regions, but many years was in another countries who return after and more from unendemic regions and characterize severe course-over disease and complicated course-over disease. For example, patient lived in endemic region, but during 5 years and more was unendemic region, lived in endemic regions, and returned after 5-10 years and clinical picture as European patient. So it will be as primary patient. During many years, aborigines leave antibodies and leave immune response, and when first after 5 years and more, repeat infected malaria parasite, clinical picture as primary patient, as will be first time infected, because immune response non-sterilized, don't last in lifelong. Why aborigines don't infect it? Because every year infected and have non-sterilized immune response. What do you do, parasites? Every time irrigated immune response and increase antibodies. When don't irrigate it, all antibodies disappear, and in with memories, self-memories, information about this pathogen disappear. The unfavorable course of malaria is indicated by convulsions that recur more often 2 times during the day, signs of shock, a decrease in the levels of systolic pressure below 70 milligrams millimeter of the Kidrargyro, impaired consciousness, hemorrhagic syndrome, and pulmonary edema. Topic? Pulmonary edema. And complications. Doctors usually registered cerebral malaria, cerebral form, when developing brain edema and hypochromic anemia. It is not a severe complication, but it's not connected with life of patient. When developing edema, disturbs regulation all function of our body. Yes, and the first time what is heart center, breathing center, and outcome death. And hemoglobin, uric fever, it's maybe don't only characterized to malaria, it is complication, but who used anti-malaria drugs developing hemoglobin uric fever. What is dysfunction of the kidney? Malaria algid, another name, infection, toxical shock. And ruptured spleen. What is the PA when developing rupture of spleen? Bleeding and outcome death. And nephrotic syndrome, affected kidney. COVID. Continue. Complications. The following mechanisms are important in the development of hypochromic anemia. Intravascular hemolysis of infected erythrocytes, it is common. The phenomenon of hemophagocytosis, in which the reticular endothelial cells of the spleen phagocytose, both infected and intact erythrocytes. Sequestration, accumulation of erythrocytes containing major parasites in the bone marrow with inhibition of gematopoiesis and immune mechanism. And immune mechanism. Do you understand? You discussed urine pathogenesis while developing complications.
What is the immune mechanism?
Immune mechanism is antibody mechanism.
Yeah,
Immune complexes represented to liver, to spleen. Have you questions? Doctors, do you understand? Mechanism of complications and indicator, signs, laboratory clinical signs of severe cause. Okay, let's have a rest to coffee break 15 minutes. After 15 minutes, we'll be discuss laboratory diagnostics and therapy. Okay? A rest. Online students, 15 minutes a rest. Are you listening to me, students?
Yes, Professor.
Stay here. I must take photo. Who is present? Online doctors, please. Thank you. disappear. One doctor and two doctors. Six course doctors. Where is six course doctors? Absent many place in WC. Doctors, please come back. Okay, doctors, I said to you, to confirm diagnosis, you must admit detected infection agent. It is parasite. It's malaria parasite. Present many analyses. Now, PCR, it's more than an examination. ELISA, enzyme analysis, but you administer and 100% confirm diagnosis microscopy. It is diagnostic is very simple. Necessary only microscope. It is last century instrument, medical instrument, scientist instrument, and knowledge of scientist, laboratory doctor. And what do you do, doctor? Microscopic detected infection agent, parasite. PCR, only informative, patient infected, but you don't understand what is level of parasite, or maybe developing mistake where you don't know what is species of parasite. And ELISA, the information patient has antibodies against malaria parasites, but what is level parasite, you don't know. And detected only antigen of parasite, but level parasitemia, it's don't absent information. And the main diagnostic method is microscopic examination of blood preparation, thick drop, and thin smell. And thick drop, from thick drop, you detected what is level parasitemia. It's necessary to prognosis. You looked prognostic clinical laboratory sign, level parasitemia. And thin smell detected what is species of parasite. And it is, what is prognosis? For example, patient infected malaria falciparum, bad prognosis. That is bad prognosis to European humans, who primary infected. And if patient you detected Plasmodium vivax, what is prognosis? Usually satisfactory and good. Don't develop it complication connected with life of patient. And the thick drop and thin smell stayed according to Romanovsky-Ginze. And the thick drop drug is used to detect parasites, determine the level of parasitemia, and monitor the effectiveness of the agetropic therapy. The thin smell preparation is used to determine the type of parasite. More than immunological and molecular diagnostic. What's molecular diagnostic? It is PCR methods don't provide 100% detection of pathogens. It is additional laboratory examination, but 100% confirmed microscopy. And it is very good because we registered now malaria in the endemic regions, but where? In the village region. And maybe in this clinic absent more than instrumental examination, but microscope present, and you may examine it and diagnose. Copy and continue. Sorry. Who is coming? Malaria testing is subjected to patients with unclear febrile condition, epidemic policy, or who have arrived from them. Patient has clinical picture influenza, but arrived from endemic region, for example, India. You must examine it to malaria. And for example, patient don't was in endemic region, don't travel. It doesn't travel, but has unknown etiology fever. And plan examination, you must examine it to all fever diseases, and including with examination to malaria, typhoid fever, examination to rickettsiosis, examination HIV infection, X-ray examination, and examination to malaria, because it is disease characterized fever. And recipients with febrile conditions with 3 months after blood transfusion. After blood transfusion, you may be infected human from if donor was in the incubation period and when donor carrier. Patients with any fever living in an active malaria focus who must be examined to malaria. Copy? And continue. Ready? Okay, wait. And requirements for microscopic examination of blood. The study is carried out both during the period of fever and during the period of pyrexia. Patient examined to malaria every day, and 2 times every day. On the moment paroxysm and apyrexia period. You must now level parasitemia. And doctors, parasitemia factor 8. And the paroxysm, apyrexia period higher, and apyrexia decrease. Why decrease? In the erythrocyte. Yes? Since in non-immune primary ill persons, febrile paroxysm occur with a low level of parasitemia, research should be carried out for 2-3 days, 3 to 4 times a day. Copy? And doctors, I said to you, microscopic. What is necessary? What is cells is constant. Erythrocytes affected, developing cytolysis of erythrocyte and constant leukocytes. And you must calculate how many parasites to constant cells. It is leukocytes. The presence of only ring shaped trophozoites in the peripheral blood preparation is a key and early different diagnostic sign of malaria falciparum. Detection with major trophozoites and schizones in the peripheral blood preparation of non-immune individuals is a formidable sign of the onset of a malignant cause of a disease with an unfavorable outcome. Doctors, please listen. My clinical case. Many years ago, in our clinic, hospitalized young man in the winter, after winter holidays and after Christmas, and our patient had traveled in islands of South America trip and hospitalized with high temperature, marked intoxication syndrome, and jaundice. What do you do? What is first a diagnosis you must be examined? Patient from islands of South America. Very good. Fever and bad condition, marked intoxication syndrome, and jaundice. He was examined to malaria, but it was at the night, and laboratory service doctor said malaria parasites in the microscopic examination absent. And doctors, if absent laboratory test, I don't make confirmed diagnosis. And many other diseases characterize, not only malaria characterize fever, and it is not endemic region. This in the region registered, and for example, dengue fever, yellow fever, and many diseases. And but you administer intravenous desintoxication therapy. Against the background therapy, patient condition worse, increased irritation, emotional lability, appear cramps, and you think, oh, it's maybe encephalopathy, viral hepatitis. I said you, viral hepatitis delta characterize fever because developing total necrosis. And you repeat, administer examination too. What is laboratory criteria severity of viral hepatitis? Tell me, please. Very good, very good. Yes, drop prothrombin. Slowly, please, drop. Yes, and you repeat, take blood, 2 examination, 2 prothrombin index, because you must know what is stage of encephalopathy. You understand it is first encephalopathy because irritated, emotional lability, cramps. But what is prognosis waiting us? And repeat, take blood and send to laboratory service. And laboratory service doctors say, did your patient use anti-malarial drugs for prophylaxis? Why this question? Because I detected single parasites in the blood. Maybe your patient used treatment anti-malaria and now level parasitemia low. No, it's another situation. Where was malaria parasite? In the tissue. Absent, I said you, all species of malaria in the bloodstream, central vessels. But malaria falciparum in the microcirculatory vessels, in the tissue. It's not characterized correct parasitemia, and it's bad prognostic sign where all parasites in the tissue and single parasites in the bloodstream. And what do? You now 4th stage of parasitemia. Stage first, high-level parasitemia, when parasites 5,000 in more in 1 microliter, 5,000 and more in 1 microliter. Second stage parasitemia, 500 to 5,000. And third stage, 50 to 500. Third stage parasitemia is very bad prognostic when you detected 5,000 and more parasites in 1 microliter. Second stage, 500 to 5,000 in 1 microliter. 500 to 5,000. And third, 50 to 500. 50 and fourth stage under 50 parasites in 1 microliter. But prognostic first stage when parasitemia more 5,000 in 1 microliter. But when you examined it, you detected how many how many parasites to 100 leukocytes, because leukocytes is stable elements of the blood. And you detected from peak of drop 50 parasites to 100 leukocytes. But you don't know how many parasites in 1 microliter, because level parasitemia calculated You understand when? How many in 1 microliter? But from hemogram, you know how many leukocytes in 1 microliter. And what do? It is a formula of primary school. 50 parasites to 100 leukocytes, but don't know X parasites to, for example, in the hemogram, you detected 4,000 leukocytes to 4,000. What do? 50 parasites multiple to 4,000 leukocytes and over 100 leukocytes. And please calculate it, 2,000. If you don't administer therapy, this parasites level increase and develop severe also the disease. Repeat it.
Yes, Professor.
You don't know, you have tissue, yes, but it is only relative. First stage, it is more 5,000 parasites, yes, and second stage, it is 500 to 5,000. This second stage of parasite. It's don't good prognostic signs because, and please tell me, you detected 70 parasites to 100 leukocytes, and what do? But what will be leukocytes in 1 microliter? What do you want? How many leukocytes in 1 microliter in your patient, for example? 5,000, okay, and 70 leukocytes, yes? What do? Please tell me. 70? 70? What do? Multiple to 5,000 and 35,000 parasites. 35,000. 35. Yes. 100. 3,500 parasites. And doctors, do you understand? What calculation? Okay. And you prognostic and differential diagnosis. And doctors, it is fecal drop and smell drop. What do you detect it? What is species? Species. Yes, species. And differential diagnosis. Differential diagnosis with diseases where increased temperature and influenza and acute respiratory viral infections. What is specific characteristic? To influenza, characterize high temperature, marked intoxication syndrome, and prevalent headache in retroorbital area, and appears dry catarrhal syndrome. But malaria don't characterize seasonality and other epidemiological data. Patient returned from endemic region, but influenza when registered in the season. What is? Usually autumn to spring season, autumn, winter, and spring season too, from October to March together. And typhoid, paratyphoid diseases, it is intestinal infection disease, generalization intestinal infection disease. When patient has high temperature, increased liver and spleen, and characterized endemicity, for example, typhoid fever prevalent registered in Sub-Saharan Africa and Indian continent because good temperature, but affected intestine characterized meteorism and appear rash, roseolus rash. It's not characterized to malaria. To malaria characterized increased spleen and liver sizes, but rash is not characterized. Roseolus rash will be discussed Wednesday, typhoid fever. And hemorrhagic fever, Lassa, Marburg, Ebola, it is hemorrhagic fevers from endemic regions were registered, and malaria too. But what is characterized? Appear rash affected a function of the kidney, and differential diagnostic search with malaria may be common. For example, malaria falciparum, the polymorphic clinical picture, and only laboratory examination. It is viruses from Claviviridae family, and from PCR you detected this virus. And sepsis, what is situation? Bacteremia, bacteria in the blood appear, increased temperature, increased liver and spleen sizes, and get character of the temperature, and regular temperature. But in the hemoculture, blood culture, you detected bacteria. And anamnestic data, before developing septic situation, patient had bacterial disease. And usually sepsis characterized to immunocompromised, to older persons who have many diseases and prolonged disease, because disturb immune response. Leptospirosis, endemic disease, don't only to characterize where many rivers and water. It is, for example, and characterized to endemic regions, as north regions of Africa too, and Asia. Leptospirosis when affected kidney, affected liver, affected kidney, developing jaundice, and if characterized fever, but appear rash. To malaria, rash is not characterized. But this differential diagnostics is prevalent.
That says Mazel Tov, I bring the trouble.
Iskander, what do you do? And doctors, differential diagnostic search. And for example, HIV, for example, pneumonia, characterized increased temperature. But if patients return from endemic regions, you examined malaria. And plan examination, if unknown etiology fever, you must administer examination to malaria. Have you questions? Continue. Management of malaria patients. All patients with malaria are hospitalized because you don't know what will be prognosis. This time patient's condition satisfactory, but next day parasitemia increased and condition worse. But when developing malaria falciparum, it is disproportionate bad prognosis, and all patients must be hospitalized. Patients with severe course of a disease or complicated forms are treated in intensive therapy department. And principles of drug therapy. Okay, return. Copied? And principal therapy, etiatropic and pathogenetic. What is pathogenetic syndrome? Characterized for all species of malaria. Fever, and if fever appear, jaundice, it is when marked cytology. Switching, it is sign of paroxysm. Intoxication syndrome, intoxication. Doctors, and you must administer etiatropic therapy, and you must administer disintoxication pathogenetic therapy. But what is drugs you administer? Why developing clinical picture? When spherozoids leave erythrocyte, and you must administer therapy against erythrocyte schizogania. Erythrocyte schizogania. Etiatropic therapy must be prescribed immediately after establishing the clinical and epidemiological diagnosis and taking blood for parasitological research practice. Before confirmed diagnosis, you don't may administer drugs against erythrocyte schizophrenia, isotropic drugs. The choice of treatment tactics will depend on the type of pathogen, the region in which the infection occurred, the severity of disease, the presence and nature of complications. For example, you have effective drug Delagil, but Delagil is not effective against malaria falciparum, effective only against malaria vivax and avalia. You administer, when you understand it is malaria vivax, you administer 1 gram Delagil this first day. After 6 hours, half gram Delagil. First day, patient used 1/2 gram Delagil. Second day, half gram. Third day, half gram. Course dose, 2.5 gram Delagil. After, stop. Disappear fever and disappear intoxication syndrome because affected what is schizons from erythrocytes against erythrocyte schizophrenia. But if you administer patients who have falciparum, malaria falciparum, it's not effective. But what do you do if Delagil affected merozoites? Products metabolism go to the bloodstream. And what do you do? What is appear? That's very good. And you understand, when you administer isotropic therapy, together you must administer intoxication therapy because the effect of anti-malaria drugs, what is increased intoxication syndrome. It is a isotropic drug, but patient has malaria falciparum, and patient many times infected malaria, and patient condition moderate or satisfactory. You may administer orally drugs against erythrocyte schizophrenia. What is malaria, Fansidar, but when patient has severe cause, developing cerebral form, patient don't may use tablets form. You administer intravenous, and intravenous drug first time it is all the anti-drug. What is quinine? Intravenous you administer quinine, but now registered resistance against quinine 2 and artemisinin. Effective drug, artemisinin. China scientists synthesize it with artemisinin, yes, and Nobel laureates who detected this drug and administered artemisinin.
We are treating for the schizons.
Yes.
And for intoxication.
Crystalloid colloid solution, common disintoxication. You discuss viral hepatitis, disintoxication therapy. And please look, anti-malaria drugs, how many groups? Against erythrocyte schizophrenia, against tissue schizophrenia, against gametocytes. Why you administer against tissue schizophrenia? Why? And together it is against hypnozoitic form, against bradiform. Prevention, falciparum. Vivax and avalia have 2 generations of schizons, bradiforms and tachyforms. And clinical picture results when tachyforms go to the bloodstream. But bradiforms waiting and activated later and recommended when stop. How many days lasting erythrocyte schizophrenia therapy, malaria vivax and avalia? 3 days. And recommended after erythrocyte schizophrenia therapy, hematoschizotrophic therapy, necessary administer against tissue schizophrenia because in the liver sitting bradiforms. It is drug primakim. Administer during 2 weeks, primakin. And therapy, malaria falciparum, don't develop in bradiforms, don't characterize severe later relapse, but if developing metacyte. And if ill, sick patient live in endemic region without persistent merozoites in the erythrocyte, that is final stage, it is gametocyte. When mosquito bite ill human or in the reconvalescence period, take waters from with blood and gametocytes. And these gametocytes sit in the saliva glands of mosquitoes, male mosquitoes, and replicated. And our aim to prevention, distribution, malaria parasites, you must administer therapy against gametocytes, act on the sexual forms of parasite. It is therapy primakin. And doctors, histoschizotropically and hypnoschizotropical, it's common because bradiforms, histotropic, it is in the hypnozoids, in the tissue. It is common. In the liver, yes. In the liver, hypnozoids. In the liver, and histoschizotropc what is against merozoids in the liver. It is common. No different. It is tissue forms and bradiforms. It's common. And our names you maybe read in the literature. Similar, yes. Histoschizotropcal, hypnoschizotropical, and hematoschizotropcal drugs. Chloroquine, it is Delagil, effective against malaria vivax and avale. But miflaquine, artemisinin, quinine, it is drug for treatment malaria falciparum. I said you, lariam, fansidar, miflaquine, it is tablet to treatment malaria falciparum. And severe cause, you administer intravenous quinine and administer artemisinin. Falciparum, yes. You administer miflaquine tablets form, fansidar, lariam, and severe cause artemisinin. Severe cause of malaria falciparum. Chloroquine, malaria falciparum resistant against chloroquine. Miflaquine, lariam, fansidar. Copied? Doctors, do you understand me? Chloroquine, it is hematoschizotrophic drug, but don't effective against malaria falciparum. Because resistant, yes, very good. Continue. Histoschizotrophical against tissue schizogania. But doctors, incubation period, it is tissue schizogonia. You don't know our patient infected or don't infected. But you administer histoschizotrophic drugs when patient infected malaria vivax and avale, because tissue schizogonia when sitting bloody forms. To stop cause hematoschizotrophic drugs, you administer against tissue schizogonia drugs to prevention later relapse, and primaquine, pyrimethamine, proguanil, and tetracycline. Recommended primaquine and pyrimethamine during 2 weeks, 14 days. It's 14 days, 10 plus 4, it is 2 weeks. 14 days. Copy it? And hematoschizotrophic drug, primaquine, why you administer? Who live in endemic region may be source of infection, because in this reconvalescent period has, what is gametocytes? Clinical picture absent, but gametocytes in the bloodstream present. Mosquitoes bite and a vector to healthy human. And to prevent distribution parasites, you administer primaquine against gametocytes, but primaquine effective and against tissue schizogonia. Please look. Histoschizotrophical. Primaquine effective against bloody forms, and together against gametocytes. And you administer 3 days. Reconvalescent patient of tropical malaria must be used primaquine during 3 days if live in endemic region. For example, patient flight to London or North America, where absent good condition to distribution, don't necessarily administer primaquine because it's not source of infection. Only when stop donors. But if patient treated Fansidar, I said you, Fansidar effective drug against erythrocyte schizogonia. But Fansidar, in the Fansidar present primaquine. If patient used course Fansidar, don't necessarily administer primaquine, because first days of treatment patient used primaquine. Why necessary now? Primaquine, doctors, each drug have toxical effect, and usually if absent rules, don't necessarily administer. Copied? Continue. And histoschizotrophical primaquine. What means histoschizotrophical? Against hypnozotical, against tissue schizogonia. And etitropic therapy. What I said to you, in patients with an established diagnosis of malaria, vivax, and avale, and malaria, drugs of the 4-aminoquinoline group are prescribed. What is Belagil, chloroquine, and I said to you how many? First dose 1 gram, and after 6 hours 0.5 gram, and second and third day 0.5 gram.
Professor, how long is it between the first and the second dose? How many hours?
First dose, patient hospitalized, the confirmed diagnosis malaria vivax, and disappear is tight. Okay, Isabella, are you present? Isabella, where is you? And doctors, first hours of the disease when you confirm diagnosis, absent time to waiting, you must administer a chatropic drug. You administer Delagil 1 gram and waiting 6 hours and administer half gram. It is first dose, 1/2 gram, first day. Second day, 1/2 gram. Third day, 1/2 gram. And usually course dose, it is 2/2 gram. And usually after first dose, first day of therapy, temperature normalized, disappear clinical picture. But you continue administer Delagil because load of parasites present, only low but present. To total eliminated merozoites, you must administer 2/2 gram Delagil.
And usually this drug is enough?
Maybe developing resistance. It's situation you must change drugs. It will be Fansidar or Lariam tablets. Isabel, please.
No, I think you answered my question. I was going to ask if this drug is usually enough to treat a case like this.
What is enough?
Just this dose, just the administration of this dose is enough to eradicate the parasite.
Doctor, usually you every time must be controlled. You administered 1 gram, and after 1 hour you must, and 2 hours you must take blood, but you continue therapy. Usually course dose 2/2 gram. Patient
But
condition good. But
by the end of the therapy, by the end of the therapy, after the third day of therapy, is it usually enough to eradicate the parasite? In a case like this of a high variant.
If you detected parasite after course dose, after 3 days, you change therapy.
Okay.
Yes, because it's difficult when developing resistance.
Okay.
You have another drugs. I said you Fansidar, Lariam. But doctors, please remember, all drugs toxical.
Okay.
Copied? Doctors, are you copied this slide? Continue. To prevent the development of late relapses in malaria caused by malaria vivax and malaria avali, after a course of treatment with Delagil, after stop therapy Delagil, you administer Primakin. It is prescribed at a dose of 1/4 milligram per kilogram per day for a course of 14 days during 2 weeks. But you don't know how many kilograms. It's 1 kilogram, 1/4 milligram. Copied? And continue. In the case of detection of Plasmodium falciparum in the blood with a mild and uncomplicated cause of the disease, in accordance with the World Health Organization recommendation, artemisinin combination drugs are used. Usually, 2 or more anti-malarial drugs are used with different mechanisms of action. Atavacon plus proguanil, artesunate plus mifloquine, administered per orally. And recommended course 3 days, 2 days, but doctors, before disappear parasites, you continue therapy. And you must examine it 2 times every day in the peak of paroxysm and apyrexia period. When absent paroxysms, every morning, every evening, every morning, every evening, 2 times every day. And to discharge from hospital, you must take 3 negative results, 3 days results. During 3 days, you must examine it microscopic. If during 3 days absent, malaria parasites, this patient may be discharged from hospital.
Professor, about the side effects of the drugs, besides controlling the concentrations and assessing
No, you don't change concentration, you only change drug.
But is there anything we can do to control the side effects or decrease them somehow?
Doctors, you don't change dose, you only change drug.
Yes, of course, but is there any other thing we can do to avoid?
Possibility resistance and combination and recommended per orally, but if patients don't use, administer intravenous too. But intravenous recommended to severe cause. But against artesunate, don't register resistance, rare, only rare. Usually our patients have resistance against quinine, but when administered artesunate, patient answer. And parasitemia decrease. Copy it? Continue. If a type of pathogen cannot be established, treatment should be carried out according to the schemes recommended for the treatment of tropical malaria. Malaria, tropical, recommended what is? No, treatment, what is? Quinine. Quinine. Treatment. Copied. Continue. In the case of a severe or complicated cause of a disease, only the intravenous route of administration of anti-malaria drugs is used, artesunate intravenously on the first day, 4 milligram per kilogram. And doctors, after, during 2 days or maybe 7 days, 2 milligrams per kilogram. But doctors, last month in our clinic, hospitalized patient from England after travel to South Africa, infected tropical malaria and hospitalized with level parasitemia 1 million. Yes, we think maybe will be dead, but patient during 2 weeks hospitalized in intensive therapy department, and you understand this therapy antitropic therapy don't last in 1 week, and together administer hemodialysis too. And after 2 weeks of intensive therapy department, patient hospitalized in our clinic, infection diseases clinic, and continue using intravenous anti-malaria drugs, antitropic drugs. 1 million. Yes, easy after, but necessary time to reconvalescence because patient had brain edema. And cerebral form, it is brain edema. And third stage of cerebral form. High-level parasitemia. COVID? It's now very good intensive therapy department therapy, this hemodialysis. Why? Because necessary from Prisma take these parasites, because these antitropic drugs don't make total effective these parasites. Necessary dialysis. And World Health Organization classified Plasmodium falciparum resistant. you must know 3 stage of resistance. The plasmodium falciparum strain is sensitive to where the drugs used. When number of parasites is gradually decreasing, they may even disappear already against the background of ongoing treatment, or by the time it ends, relapses are not occur within the control period of dispensary observation, 28 days, a radical curve. You must be classified stage of resistance. Okay. Continue. And second, resistance degree of this stage 1. Yes, the number of parasites gradually decreases to submicroscopic level already in the process of treatment, and by the end of treatment, parasites are not detected in the peripheral blood. Within the control period of dispensary observation, 28 days, a relapse occurs, clinically expressed or only parasitic. Resistance, first stage degree. Copied? Second stage degree. The number of parasites decreases in the course of treatment, but by the end of treatment, parasites are still preserved. The resistance of the resistant second degree, which requires urgent replacement, a specific treatment. Copied? And third stage resistance. Despite the specific treatment carried out, within the first 48 hours, parasitemia doesn't decrease, and in the subsequent periods, it may even increase, which requires urgent replacement of specific treatment. Doctors, and usually bad prognostic, third stage resistance. And doctors, it's problem in our country. Our country is not endemic country, and pharmaceutical company don't buy this drug and don't register it, because in our clinics present only quinine and Delagil, but artesunate, it is drugs necessary to treatment resistant and severe cause of malaria falciparum. In our country, it's not registered. And you take these drugs only when patient, for example, who walking and treating in endemic regions, buy and have these drugs too. And usually what do we do? From embassy take these drugs. We have bank of these drugs, but in our country and in history of disease, patient hospitalized with drug, and for example, members of the family buy this drug. But these drugs you don't may buy in our country. Absolutely. Only from in our countries, endemic countries, take these drugs because it's don't registrated. Because you don't buy these drugs. This pharmaceutical company must be. But how many? 100 tablets? No, don't necessary, and don't buy. But in endemic regions, this drug is registered and present.
So, if a patient gets stage 2 resistance,
no, in Moscow, present bank of these all drugs. Yeah. You have it. And when was World Championate, many patients with tropical malaria hospitalized in our clinic, and don't register one little case. Register severe cases of disease, but don't register little case because we have banned these drugs.
So it is with the embassy or with the Russian?
You have contracted
Okay.
and clinical examination. Persons who have had malaria caused by Plasmodium vivax, avalia, and malaria have been observed for 2 years. Any increase in temperature requires a microscopic pathological examination of the blood. After 1 year, maybe later relapse characterized by Plasmodium vivax and avalia, but Plasmodium malaria persisted lifelong, maybe resisted 10 years or maybe lifelong. Persons who have had Plasmodium falciparum malaria should be followed up for 1.5 months with a parasitological microscopic blood test every 1 to 2 weeks. It is clinical examination and prevention. Doctors, vaccine every time synthesis, but vaccine now is not effective. Effective vaccine in our world now absent against malaria. Recommended only chemoprophylaxis, but chemoprophylaxis may use on the humans who go to endemic regions only to short time. For example, travel. But when who go to these countries to work in many years, don't recommend it chemoprophylaxis. Why? Because it is chemoprophylaxis toxic. And the affected liver, affected kidney, don't recommend it using to pregnant women who have psychic diseases, patients. And recommended only rules of organization, recommendation, it is miflakin. But now, I said you, our century, resistant century, registered resistance against miflakin. And in our clinic, hospitalized humans who used miflakin, but developed infected malaria falciparum. And the recommendation who go to short time to travel, recommended before 2 weeks go to this endemic region, 1 drug, 250 milligram, use 1 time in the week. For example, your aircraft will be next Monday, and you must use this Monday, next Monday, and Monday when you fly to endemic regions. You in the endemic region 1 week. This next Monday you repeat use miflakin, and when you return to your country, 4 Mondays you must each use miflakin 4 times, 4 weeks, but 1 time in the week. And how many doses? 2 weeks before going to endemic regions, 1, 2, 3 weeks when you present in the endemic regions, and plus 4 weeks. Usually how many tablets? 2 plus 4, it's constant, and maybe different. 1 time tablets, maybe 2, maybe 3. How many weeks will be this patient? But doctors, it is drug now resistance. You may be recommended, but patient must now may be infected 100%. This drug is not effective. Do you understand? Have you questions? No. If absent questions, online doctors after 30 minutes go to you link teachers. Do you understand me?
Yes, Professor.
Okay.
Yes. After 40 minutes. And you have 40 minutes to lunch too. Okay.
Thank you.
Thank you, Professor.
Goodbye, doctors.
Goodbye.
Goodbye.